Hello, GRI University. My name is Tim Benke. I am a pediatric neurologist at the University of Colorado and Children's Hospital, Colorado. I'm going to talk to you today about existing treatments and drug development. These are my disclosures. The important ones are here, that I'm involved with the functional and clinical evaluations of glutamate receptors, mutations, and epileptic encephalopathy studies, sponsored by Simons, that lives at Emory, where Dr. Trainellis is the PI. I'm also scientific advisory for GRIN2B, GRIN Therapeutics, and Cure GRIN. So we have a lot to talk about today. I'm going to talk about some existing treatments for epilepsy, spells and storms, sleep, GI, and therapies in general. I'm going to talk about N of 1 trials and some clinical trial basics. So it's a lot to cover. Seizures and spells. So here are some important key questions that you should try to review with your clinicians. You want to be able to describe the events from start to finish. On average, how long do they last, and what's been the maximum duration in the past? When did they start? Are they still occurring today? How often do they occur now, and what is the maximum frequency in the past? What happens afterwards, such as sleep? Does anything trigger these? Does anything help? And were they ever captured on an EEG or other physiologic recording or your cell phone? For spells, what are the possibilities? This is important because it helps define what the treatments are. The description plus diagnostics hopefully gives an answer to suggest therapy, and this is a clinical decision that you come to with your clinicians. It could be a seizure, movement disorder, sleep disorder, autonomic instability, a change in anatomy, behavioral, or sometimes you're just left with unknown. But ultimately, the treatment goals are no seizures, no spells, and no side effects. However, this may be a balance that you establish with your clinicians. What are some diagnostic tests to consider? Well, a cell phone video is great because it catches the event in its natural state. The cons are it's hard to do. You sometimes need a third arm. And there's, of course, limited physiology that's recorded as part of this. Video EEG, this is the ideal recording condition, but you have to be lucky enough to be hooked up at the time to capture one of these. Sleep study with a video, same sort of situation as an EEG. These are ideal recording conditions, but you also capture additional physiology. And the cons are also you just have to be lucky enough to have a spell and capture it at the same time. An electrocardiogram or Holter monitor. These are ideal for capturing cardiac physiology. Also, same issue, you have to be lucky enough to capture them. Imaging, such as another brain MRI. These are useful if there's been an overall change in your child outside of the spells that's there and it's a new change. But otherwise, it's not really useful or needed if it's already done as part of an initial diagnosis and there's no other change other than spells. Seizure classifications. This is important that you work with your clinician to ensure that you're on the same page. So if you decide that there are 2 different spells and you all eventually decide that this is a seizure, and that it was a tonic seizure, try to use the same terminology. If everyone's okay knowing that you're calling a whoopsie a specific seizure type, then that's okay. And spell B, everybody knows this is not a seizure. And of course, differentiating some seizure types is difficult, but the bottom goal is it's important to keep a drop diary of the different spell types to track what is working and what is not, and the side effects for each spell type. Standard therapy for each seizure type should be considered because specific seizure types often have specific therapies. And just to mention the registry, as part of that grant with Dr. Trainellis, if possible, asking your clinician to help you fill out the forms may make things easier, or you can be sure to send us their notes if you're not sure. Seizures and spells. So a quick wrap up that the therapy always depends on what caused the spell, the nature, the physiology of the spells, the impact of the spells, the side effects of medications, and the safety and efficacy of approved medications. You'll notice I haven't talked a lot about neurostorms, but essentially each one, in my experience, is quite different. And so if it's not a seizure, then specific discussions with your clinician and trying to figure out what are the specific symptoms that you're trying to target is often the way to proceed. Safety. It's always important to ensure safety during a spell, and I refer to these as the 3 T's and a 4th T of seizure, but also spell first aid. Time it. 5 minutes for seizures is our cutoff. For spells, it's less clear, but we know that we don't want seizures to last longer than 5 minutes because that's the time when we usually like to give a rescue medicine. For seizures, it's important to be on your tummy or your side in order to protect the airway because a lot of times individuals will throw up with a seizure. Tongue, don't worry about it. Your child's not going to swallow their tongue. And if you feel that you're able to pull out a third arm and you're able to T-Mobile or capture it on a cell phone video, that's often useful for your clinician. Sleep disorders. This is my approach to addressing the issue of not sleeping at night. The questions are really, is it a part of initiating sleep, maintaining sleep, or both? The other main issue is are there other things that are going on during sleep, such as snoring or excessive movements? Another important question is your child too sleepy during the day because they're not sleeping at night? And some folks are just ravers. They don't sleep at night. They often don't sleep for several nights in a row, and then they crash. And it's important to know if that's the situation as well. With regards to sleep, it's important to make some environmental adjustments as much as possible. Set the atmosphere, make sure that there's a safe space in the bed, and you have your routines down, and you go through the same routine every night. Think about, is there anything else that's part of sleep that is making things difficult, such as reflux or constipation? If nothing can be figured out with some of these types of measures, then I think of medication trials. If there's an issue with initiation, I think of melatonin or melatonin agonists. If there's difficulty with maintenance, melatonin is often not very helpful in that regard, but melatonin agonists, clonidine, gabapentin, or trazodone can be helpful. If there's other issues such as snoring, I think it's really important to work with a sleep specialist and consider a sleep study. GI issues. Just remember, this is all part of the autonomic nervous system, and glutamate receptors are needed here for function as well. Thinking about reflux and constipation is important because treatment improves nutrition, health, and especially quality of life. When it comes to reflux, some questions are, is your child irpy-burpy? Do they swallow air? Are they refusing food? Are they overeating? Are they not sleeping? These can all be signs, subtle signs of reflux if you're not overtly seeing it. One of the ways to address this is try to adjust the diet, and if this doesn't help, then consider a trial of medications. And taking most daily medications are okay. Constipation. The goal is one soft bowel movement every day. Try to adjust the diet, and then if this doesn't help to achieve this goal, then consider a trial of medications. And also, daily medications are okay, even for long periods, such as for a lifetime. And you don't want to keep doing a cycle of using the medicines and then backing off, and because otherwise there's too much fluctuation. Find what works with doing the same thing every day and try to stick to it. Feeding. Coughing, choking, spluttering, taking more than 30 minutes, or a flat weight curve. These are important signs to consider that proper nutrition is just not getting where you want it to. And it often feels like a failure to parents, but sometimes you need to consider a gastrostomy too. Nutrition. I think it's very important to work with a dietitian and make sure that the adequate nutrients are being obtained, and to consider a vitamin D supplement, especially if you're on anti-seizure medicines. Therapies. I think it's very important to consider physical therapy, occupational therapy, speech therapy, augmentative communication. With a lot of our patients, it's very important to do a vision assessment and make accommodations in the educational plan if needed. And often an individualized education plan needs to be formed. It's important to know your rights under the law with regards to these issues. And there is a very important and useful website, check out rightslaw.com. If you want to look at a comprehensive guide in another disorder that may be of use, and I think it can certainly be applicable to some of our patients with GRI disorders, please check this reference out here for Rett syndrome. So what are N of 1 trials? These are an individualized approach and outcomes for each person. So an outcome measure is what you're trying to target, and it depends on your preference. And what you're trying to figure out is what you're doing really working. Meaningful change. So it's important to decide ahead of time with regards to that outcome measure, what is going to be useful to you in terms of continuing with the therapy. But this meaningful change is subjective to each person's experience. And what works for you may not work for everyone else. In other words, how do you know if something improved for you, it was going to be really useful to everybody else in general? Prior safety for these medicines hasn't already been established, and safety measures can be arbitrary. And it's need to be thought well through ahead of time. What do you measure and how often to make sure things are safe? If there's an improvement or worsening, it's difficult to know, could this be the medication, or would this have happened anyway as part of the natural course of the disease without the medication? So when these N of 1 trials for GRI disorders, the choice of therapy depends on prior knowledge of the functional status of the specific change in your GRI receptor. Is it a gain of function or is it a loss of function? Because each of the N of 1 therapies is dependent upon knowing that. What we know so far for loss of function, using a medication called L-serine, it's been reported that in GRIN2A and GRIN2B, there's improvements in behavior, development, EEG, and seizures. And there's 2 papers that are out there in the literature. One is from Ilona Cray and her group, and reported the largest series of 10 patients, and 9 of those patients appeared to have some improvement, but one of them got worse, and it turned out that this individual had a gain of function change, which is why it's important, gain or loss of function. For gain of function changes, memantine, dextromethorphan, magnesium, and ketamine have been considered. For GRIN1, GRIN2B, and GRIN2D, there's been improvements in medically refractory epilepsy and status epilepticus. And overall in the literature, that's a relatively few number of patients that have been reported, as I note here. 1 in the paper from Zhu et al., 4 in the paper from Platzer et al., 1 in the Pearson et al. Paper, another 1 in the Amador paper, and then 2 in the Lee et al. Paper. So the experience is largely somewhat limited. So in my opinion, these are helpful to understand safety and support going forward with standard clinical trials. I'll talk to you about what that is. But for these N of 1 trials, it's in my opinion that these should be only for extreme situations, such as ICU admissions, multi-daily seizures, or something else that's you and your clinician decide is very impactful. And there is a genuine discussion about the benefits and risks of trying something like this, because I think it's experimental. And it's important that the functional status is known. And if this comes up, your clinicians can also contact me at any time for recommendations about what I might try in any particular situation. So, clinical trials for GRI disorders, here we are. So this is where we want to be, treatment specific to GRI disorders. And how we have to get there is we need preclinical research and research through the clinical trial process. And it's important to remember that this is research and it's not treatment, even though there might be the possibility of some treatment-related benefits to your child. Basically, the goal is to have a successful trial, which leads to FDA approval, and then availability of treatment for all people. Ideally, that's how it's supposed to work. As a patient and family, it's important to ask questions, get informed, and please enroll in trials. And of course, be patient with the process, because it is a process. So I think it's important to go over some clinical trial basics. So what is a clinical study? What is a clinical trial? So this is a process by which subjects and caregivers consent and assent to participate in a defined study designed to produce information that can be used to understand or help the population as a whole. This data is peer-reviewed and published to advance the knowledge and effective and safe treatments of the disease. Trials are interventions. Voluntary, you don't have to participate unless you want to, and you can withdraw at any time. A review board must approve the trial before any subjects are contacted and enrolled, and there are international rules of standards and ethics that are applied. Safety is always the most important thing. There are specific but broad assessments that are required during the trial. There are phases in clinical trial. Each phase is typically a separate clinical trial. Phase 1 is testing healthy volunteers in multiple doses. It may be in patients with advanced stages of a disease or disease with no known treatments. Safety is primary. Phase 2 is testing on patients for efficacy and safety. And phase 3 is a confirmatory trial testing on patients for efficacy, effectiveness, and long-term safety. Phase 4 is long-term safety assessments. And the FDA will typically approve for use after phase 3. And this may be different or exceptional, however, with gene therapy because this is very new territory. There are different types of clinical trials. There's a placebo-controlled trial where a placebo or sugar pill is used to make sure the effects are real. And it's important to note that patients with epilepsy can see a 25% reduction in seizures with the placebo. I've got another slide to show for you about this in a second. Randomized, that means who gets placebo or drug is a flip of a coin. Double blind means that the subjects and the local study personnel do not know who is getting drug. Open label means everyone's getting a drug. Crossover means those getting the drug then get the placebo and vice versa. It's usually randomized and double blind too. Extension. This is access to the drug after the trial ends, and it's usually an open label continuation of the trial. The gold standard is randomized double-blind placebo, but it's thought that this is not going to be true for gene therapy trials. So I wanted to talk a little bit about the placebo effect, and this is what was seen in a blinded Rett clinical trial. So Rett syndrome is a different genetic disorder, and basically individuals with Rett syndrome were treated double-blind in a randomized clinical trial. And so this is study day over here, and this is change from treatment baseline in a score that's specific to Rett syndrome called the RSBQ. So if you went down like this, your Rett syndrome symptoms actually improved. So the individuals who were getting placebo, they actually improved by a few points in this measure. However, it's important to note that those that got the drug did have a bigger improvement. And this was also seen in another measure called the CGI. So again, individuals who were getting drug had demonstrated improvement to both the clinicians as well as the parents on this particular measure. However, there was a bigger difference as the trial went on between the two groups. So that's why it's important to have this placebo control group, but also have a very structured trial that lasts for an extended period of time so you can really tease out if there's an improvement or not. So clinical trials, what to expect as a participant. We live by the protocol. So basically, you can't make any exceptions. You've got to go with what the protocol says. The first thing is the screening visit, where you make sure that you meet the inclusion or exclusion criteria of the trial. You sign a lot of paperwork, and there's often a lottery or industry approval of who gets to participate in the trial. The inclusion and exclusion criteria, these are usually things like age, weight, disease specifics, other medication use, recent trial experience, and there's no exceptions. The clinician at the site can't change these rules. They're already set in stone by the company. The duration, this is duration of treatment and follow-up during the trial, and study visits. These are specifically time for the trial to get good data. Like in the Rett trial, everybody got evaluated at specific time points. And so they're not that flexible, usually plus or minus a day, not weeks, and not optional. So it is an inconvenience to participate in a trial. You've got to change your life to fit the trial. The study coordinator is somebody who works with the families to try to fit it into their schedule. And they happen over the duration of the trial. Try to make things as much family-friendly as possible, but it's important to get good data. The endpoints and outcomes, these are the measurables to determine safety and efficacy. Clean data is the goal. It means you have to be very careful about meeting the exclusion criteria and inclusion criteria. And we want to make sure that when something's approved, that we can feel confident that what we're offering is safe and effective. And it's important, again, remember, this is research, it's not treatment. The medicine that's being trialed, it could help or not. It's very different from when if your clinician offers you something that's been approved. And then post-approval, this should be available to all. Good data. Another thing to remember is having the same caregiver present for visits ensures consistent data. This also brings in some issues with regards to travel if you have to travel for a trial. So being in a trial, just a visual. So there's a screening visit, and then there's a flip of a coin as to whether or not you're in a treatment group or a placebo group. That's the randomization. Then there's specific clinical trial visits. Then there's a final visit, and then the drug might continue after the trial. After that finish line, then that data gets taken and it's evaluated to determine if the drug is safe and efficacious. So clinical trials, what about the patient voice? So what types of trials are acceptable to this group? This is an important question. What types of symptoms should be treated? How are they assessed? What are meaningful symptom changes to a family? And how does the age of the individual impact these questions? So understanding the patient voice is something that we need to hear from you. And we, meaning especially the FDA, they often do something called patient-focused drug development meetings. And there have been some recent meetings for both Rett and CDKL5 disorder that I think it would be important for the community to take a look at. And here's some links to those there. And it's important to capture the outcomes correctly. And one of the ways that we're trying to do this, of course, is with the registry that we're doing here. And Johannes Lemke is doing for Europe. And then eventually, at some point, we would like to have even more clinical data to inform the natural history. So clinical trials, why does it take so long to get started? Well, of course, you need preclinical data first with looking at efficacy and safety in animals. This happens in academia and industry. And then there's outcome measure development and natural history. Second, there's solicitation of the patient voice. This often happens by industry. Then there's human protocol development, and the industry often does this. And then federal regulatory approval. Sometimes this takes 5 to 10 plus years. Then once a trial starts, there's site recruitment and approvals, there's contract and budget approvals, site ethics board approvals, then site initiation visits happen. Then enrollment finally begins, and we can call you and you can show up. And this is where we are. We're still in steps 1 and 2. Clinical trials, where do you get information? Well, one place, of course, is Facebook, but Facebook has contaminated trials in the past. So don't be that guy that ruins a trial for the rest of us by posting. Email, internet, blogs, me. I'm not going to endorse any particular trial, though I'll participate in some. But the important thing is to trust but verify. The only real sources are clinicaltrials.gov or sourced from there, and the company website, but also importantly, the consent form for when a study starts, and the study investigator can tell you after it's approved by their regulatory board. As mentioned, it's important to bring up the registry. If you haven't enrolled, why not? And this is the pathway to advanced functional analyses in order to determine if you're gain or loss of function. And it's the pathway to discovering natural history. There's a new portal that's a one-stop shop for all. But if you're in Europe, Asia, or Africa, here's the link to Dr. Lemke's website. And then in North, South America, Australia, here's the link. If you can email Jennifer Sargent or Jennifer Bain, these are 2 different studies collecting different but very similar and important and complementary data. So we went through a lot. I think I probably went over time, but I thank you very much for your attention. And you can get in touch with me through Pure Grins. Thanks very much for your attention.